Chapter 39. In Chapter 39, we'll be covering abdominal trauma. It's a relatively short chapter. In fact, everything for this week, which is week 14, is relatively short chapters and relatively easygoing. So we're starting to pull into the end of the trauma section of the course here. So we're going to wrap that up actually probably next week when we talk about multi-systems trauma. But for this week, we'll talk abdominal trauma, spinal, and environmental emergencies. So, abdominal trauma, of course, we know is a potential killer when it comes to traumatic injuries because it can hide a lot of blood in the abdomen, where we do have quite a few organs that play extremely important parts in the homeostasis of our body. Although they may not have immediate negative consequences from some of those being injured, they certainly all can bleed very, very heavily, and that can lead to obviously hypovolemia and irreversible shock. We're still working off of the education standard that says that AEMT will be able to apply the fundamental knowledge to provide basic and selected advanced emergency care and transportation based on the assessment findings for an acutely injured patient. There's one multimedia video for this week that you can find in the non-narrated PowerPoint talking about liver injury, and just a few handfuls of objectives that you'll find on pages 871 and 872 in your text. So, like I mentioned, these abdominal injuries can be significant bleeders, and if they go unrecognized, much of that abdominal trauma can be a leading cause of death of trauma patients. Patients with abdominal trauma sometimes don't immediately look like they have severe abdominal trauma. They may have more discrete symptoms. They may not have severe complaints of pain and whatnot, and that goes along with not being able to see this blood rushing out of them because it's rushing into their abdomen hiddenly, and we don't often immediately pick up those signs. So it makes it kind of a mystery. So when we're looking for patients or when we have a patient who has signs of shock, but yet we don't have any outward signs, don't forget to look inward. In many cases, we look at the mechanism of injury, and that mechanism of injury can help us to think about, at least, whether or not this person may or may not have an abdominal injury. So we will need to always maintain a high suspicion for intra-abdominal injury. Anybody who has a significant mechanism of injury that we've already learned about way back in the beginning of the trauma section, medium to high speed crashes, falls from 3 times greater than your own height, penetrating trauma, sometimes even blunt trauma, so on and so forth. If we believe the potential is there, we should be considering it. Remain alert for the signs and symptoms of internal bleeding and shock. There may not be any visible external injuries to the abdomen. Now we might want to think, oh, well, if we see a seatbelt mark across their abdomen, I probably don't need to consider it. Well, when worn correctly, a seatbelt is worn lower over the pelvis, and it may not leave a mark because all the pressure was put onto the iliac crest. But that doesn't mean that the shifting, if we go back to the kinematics of trauma, we talked about the 3 collisions that occur in a motor vehicle crash. First, the vehicle with the other object. Secondly, the person's body with the inside of the vehicle. And then thirdly, and in this case most importantly, the internal organs shifting and crashing with the insides of the cavities. So in those cases, we may have things like livers that get jostled around or spleens that get pulled on, and those sorts of things can obviously lead to injury. And of course, penetrating and blunt trauma have that potential. So think about it goes with your case study. So to recall a little bit our anatomy and physiology, we have two major areas of the abdominal, we'll call it region, that we have to be concerned with. We have the intraperitoneal abdomen, or what we commonly think of as our abdominal content, things like intestines and stomach and spleen and liver, gallbladder, as our major components that we'd find intraperitoneally. But we also have retroperitoneal items, so things that kind of sit back in little pockets that kind of got carved out in the muscle tissue of the back. And that would be things such as your kidneys, your greater vessels, so your aorta as well as your inferior vena cava. The spine, of course, sits back there. The pancreas kind of sits along the edge, up underneath the stomach, kind of sandwiched underneath the stomach, but beside the spleen, and sitting kind of in that little back pouch there. So we have two major areas. The retroperitoneal area, luckily those things are packed kind of tightly, so we don't have to worry as much about them shifting around. But with that, there's little room for a little bit of bleeding to occur. So if some bleeding does occur, then it becomes kind of a bigger issue. So the abdominal pelvic cavity, we not only have organs that are part of the circulatory system, such as our greater vessels. We have digestive organs, which is the majority of them, endocrine organs. Now remember, endocrine organ has to do with hormones, so that would be the things such as the adrenal glands on the kidneys, the pancreas, as well as a few other endocrine properties when you look at things such as the reproductive tissues. We, of course, have the reproductive organs, which sit down in the pelvic bowl, or externally in the male's case. We have parts of the lymphatic system, which we don't talk a lot about the lymphatic system. It's really kind of one of the forgotten systems, because it doesn't do a lot that we consider to be critical, but it's really kind of like your sewer line coming into your house. Once it quits, problems start to abound. And of course, the urinary system. Most of these things are held in place by what is referred to as the mesenteries, and the mesenteries are kind of like, think about a saran wrap covering that goes around everything and kind of seals it in, protects it, holds it into place. Imagine getting, I'm sure some of you have purchased a product in which you basically had to use the jaws of life to get it out of that hard overall plastic package that it came in. And then there have been a few products that I've run into that even once you get that open, there's inside plastic that is vacuum sealed on everything dang near to get each individual piece, part, and component out. And it's a lot like that we have this extra covering in there that does a fantastic job of holding things pretty well in place, and it kind of makes everything interconnected and intertwined. And then, of course, we have the peritoneum, and the peritoneum is our thin, double-walled epithelial lining that surrounds the abdominal organs. So not only do we have mesenteries kind of suspending everything, but then we have the layer of the peritoneum, both parietally, which is the inside of the abdominal wall, and viscerally, which is the outside of the individual organs themselves. So we have extra layers of protection in there. The four quadrants of the abdomen, we've gone over this and gone over this. I don't think we need to dwell on this much, but remember, the majority of the lower quadrants are almost identical to each other, with the exception of the right lower quadrant having, in most people, the vermiform appendix, which comes off just at the ileocecal valve, basically, where the small intestine and the large intestine come together. The little appendix hangs off there. But yeah, we've got large intestine, small intestine, ureters, ovaries, and fallopian tubes in the female. Whereas in the male, of course, you won't have the ovaries and the fallopian tubes, and the majority of the male reproductive organs outside. Along the midline, you have the bladder, the uterus in the female, prostate in the male. We, of course, have the greater vessels that travel along the midline. And in the uppers, we have on the right side mostly liver, the gallbladder, a little bit of stomach, a little bit of pancreas, and the small and large intestines. And on the left side, we have a small and large portion of liver, a whole lot of stomach, most of the pancreas, the spleen, the left kidney, and then small and large intestine as well. Retroperitoneally, again, we have the kidneys, the ureters, somewhat of the duodenum and the colon, and the pancreas that kind of sit along that back layer there. So, and then for assessment, we generally will divide the abdomen into 4 quadrants. Just as a brief reminder, in the world of medicine, physicians actually look at the abdomen being divided into 9 regions. So 3 upper, 3 mid, 3 lower, or you have things such as the iliac regions, the hypochondriac region, the epigastrium, and so on and so forth. So they kind of divide it up a little differently than we do. Remember that the organs can be either soft or soft. And when I say soft, I should say hollow. They're either hollow or they are solid organs. Remember, hollow organs tend to spill their content, which is usually not good for the tissues, and solid organs tend to be extremely vascular and bleed. And this slide just basically backs that up. It says when solid organs are hit, they don't tend to give much, and when they do, they tend to bleed, and it is possible that a person would exsanguinate or bleed to death in the abdominal cavity by having one of those organs damaged. This reminds us of our hollows versus our solids. Another thing to think about, pediatric patients. Pediatrics don't have the musculature mature enough to provide a lot of protection for their abdominal organs. This is the reason why babies can't sit up for 6 months and can't walk for almost a year. They don't have the muscles on top of the walking. They don't have the neurologic control as well. But they don't have the muscles to keep themselves upright. There's almost no muscle tissue there when they're born. So they have to build that up over time, and that's where they then become able to sit up and then eventually walk and do the fine motor movements. In the adult population, and of course more and more in the pediatric populations these days, we're also building up a fat layer in there that gives another protective layer over the abdominal contents. So, I mean, those people that have abs of steel, the 6-packs, 9-packs, my preference is I have a keg. Everybody knows that's better than a 6-pack. But the more you have built up there, the greater chance you have of protecting those internal organs. So now my keg, my adipose tissue, my fat that I've built up there is going to have a lot more give than if I would have that 6-pack or 9-pack or whatever that people get built up there. And there's so much more strength, obviously, and structure in the muscle tissue than there is in the adipose. So some of our organs are very large in comparison to the size of the abdominal cavity, particularly in the pediatric population. Not to mention when we're talking about the pediatric immaturity of their structure, the skeletal tissue is not well ossified. So we don't have a lot of nice strong bones. So part of that liver that's tucked up underneath the rib cage, it goes fairly unprotected. So with this very large, some of these large organs like the liver being prominent there, being not well protected, it puts them at a much higher risk and a much easier possibility of having a life-threatening injury to one of their organs, such as the liver. So, in general, when we're going to go and assess these patients, of course we're going to identify mechanisms of injury or the potential for an underlying injury. So they get very easy to overlook. Patients will have these distracting injuries. They may have an altered level of consciousness. Maybe they're having some slight difficulty breathing. And it draws our attention away from the abdomen, because in most cases the abdomen isn't obviously injured. I mean, when we have somebody that has an abdominal evisceration, so they have half of their small intestine hanging out through their abdominal wall, that gets our attention right away. But most other people don't have lots of outward signs that something's going on in there. It's not until we actually get our hands on their abdomen and start palpating that we maybe say, oh, that's kind of firm. Oh, or we get from the patient, oh, that's really tender. Don't push there. So it's easy to overlook those things. So when we're starting to do assessments on patients, and we're doing that quick once over head to toe, not the detailed, but the quick once over head to toe where we give them a good look from top to bottom, we need to note things like abdominal distension and have that be a sign. Look for those small bruises that are starting to form, particularly around the belly button, because those can be things that can start to go, I wonder. And so those are some of those little hallmarks we need to make sure and look for. Obviously, always maintain a high index of suspicion for intra-abdominal injury. Remember, there's three areas of the body that kill people and kill people now, and that's the head, the chest, and the abdomen. So look around the scene for objects that create injury. So there's plenty of these things, even in a vehicle. Is the seatbelt worn wrong? Was the seatbelt not worn at all and they crashed into the steering wheel? Was it a lateral impact or a T-bone accident and the person actually shifted in their seat sideways and collided with that console in between the two front seats? Was there something that jammed right into their side, busted a rib, or protruded in enough that it caused some damage to an internal organ? Did they have something on their lap? Did they have stuff floating around in the car? Did this person fall off of the scaffolding that they were using to put in a window or paint a house or whatever and catch a couple times on the way down? Which normally we would equate with, well, that's actually going to be better for them than to fall 30 feet and have the only thing that break your fall be the ground. If you hit a few things on the way down, that at least slows down your momentum and you don't have quite as devastating of an injury. Well, you may not have as devastating of a neuromuscular injury or a skeletal injury, but you certainly have the potential to rupture some things. Say your abdomen strikes on a bar of the scaffolding on the way down, there's certainly that potential. So we also look for things such as the motor vehicle crash. How fast were we going? How much intrusion into the vehicle do we have? We look at the other factors. Did anybody die in this incident? So there's lots of potential things you can take into account. So here's kind of a reminder about mechanism of injury in a motor vehicle crash. How fast? What types of vehicles? Was this person in a smart car and they came in and they were hit by a semi? If more than one vehicle was involved, how fast were they going? What type of collision? Head-on versus lateral versus rotational, rear or rollover? Was a person ejected? Were they restrained? What path did the patient follow? So were they an up and over or a down and under? And are there any deformities to the steering wheel, the dash, and or windshield? So what are some mechanisms of injury that could lead to abdominal trauma? And I kind of touched on those previous to the last slide when we talked about things such as seat belts, falling and catching on something, getting hit in the abdomen with a blunt force trauma, stabbed in the abdomen. Of course, we could have things such as falls where we hit just right. And what position might the patient be in for the most comfort if they have an abdominal injury, provided that we don't have to do any C-spine immobilization or we don't have to control their own airway, and we are able to allow the patient to seek a position of comfort. It's usually with their knees flexed, so drawn up towards their chest. Usually then they don't go as far as curling up into a ball, curling up into the fetal position. Most of the time it's just with their knees somewhat flexed. So sometimes we sit them up slightly, we put them like semi-Fowlers on the cot, and maybe put some pillows or blankets underneath their knees to help take that extra pressure off of their abdomen. Of course, if we suspect a spinal involvement, we're going to have to manually stabilize and then, of course, work our way to the long spine board. Remember, pale, cool diaphoretic skin typically indicates shock. Rapid transport is a must. Remember, these people can be fixed really only by a knife. So, determine their chief complaint, inspect the abdomen with our DCAT BTLS, palpate all 4 quadrants. If we know ahead of time that one of those quadrants is particularly tender, we start as far away from it as possible and work our way there. Remember, we may also be dealing with an evisceration. Evisceration is when organs have protruded through the abdominal wall. And there's so much room in that abdomen because we have so many hollow organs, we have the potential for there to be some squishing of organs going on in there. And in those cases, we can really fill a lot of blood into the abdomen, and it makes it much more difficult for us to makes it much quicker that shock can result. If the patient has abdominal distension present, we need to assume that the patient has lost a massive amount of blood. Now, that can be difficult to determine as well because you don't often know all your patients. So is this person really just a little on the heavy side, or are they truly, do they truly have some abdominal distension going on here? It may be something you need to ask the patient, ask the family members about. Usually with abdominal distension comes some firmness to their abdomen. So is their abdomen kind of rigid to palpation with this distension that we are suspecting? So some general signs or symptoms of abdominal injury: contusions, lacerations, or penetrations, pain or tenderness upon palpation, distension, lying in a position of comfort with their knees drawn toward their chest, ecchymosis to the umbilicus or the flank, which are relatively late findings. So to the umbilicus is called Cullen's sign, and to the flank is Gray-Turner's sign. Both of those indicate retroperitoneal bleeding or some bleeding in the abdomen. So we may also have Kerr's sign. Kerr's sign is when we have a complaint of pain in the left shoulder, which can be caused by diaphragmatic rupture. And then signs or symptoms of shock, of course. Guarding, where they really tense up their abdomen. And then the presence of a mechanism that basically gives us strong suspicion. Okay, I mentioned Kerr's sign or Kerr's sign before, and that is the pain in the left shoulder. It's referred pain caused by diaphragmatic or irritation. Remember, pain in the right shoulder is a referred pain from the gallbladder. And observe for abdominal guarding. Sometimes this is an abdominal muscle spasm caused by like peritonitis. Sometimes it's the patient just anticipating that you're going to push on their belly, tenses up their belly. So you may need to tell them, look, I need you to try to relax. It might be tender for just a moment, but I need you to try to relax and allow me to check your abdomen for any injuries. We maintain ABCs, of course, just as we do with all of our patients. That is our primary concern, is maintaining ABCs, treating for shock, keeping them warm, giving them O2 as necessary. We don't necessarily elevate the legs. However, in this case, it may actually help them with their discomfort, provided that we maybe don't have any suspect of spinal trauma, because if we suspect spinal trauma, we've got to be cautious that we don't irritate the spinal injury by elevating their feet. So we can't really, in most cases, control the bleeding simply for the fact that we can't do direct pressure on the inside. Don't forget that occasionally, though, something like mass pants, PASG, may be beneficial in helping us in the treatment of severe internal bleeding. Failure to identify and treat life-threatening conditions increases their morbidity and their mortality. So shootings and stabbings, remember that there's also a crime scene there. Your safety needs to be paramount. Don't forget. Take your precautions to preserve that crime scene the best you can. Moving stuff can often greatly affect the criminal investigation that's going to occur. And then you may obtain information about objects used in stabbings or calibers of guns. Make sure and pass those on to law enforcement. So to talk a little bit more specifically about types of abdominal injuries, we may be talking something like blunt trauma. Blunt trauma is the most common type of abdominal injury. Mortality rates of 10 to 30%. Open injuries are actually easier for us to identify, obviously, because they're a bleeding source, and usually they're much more visibly prevalent than is something like a blunt trauma, some mild bruising that maybe hasn't even started to darken yet. Closed abdominal injuries, you're going to have to rely on your assessment skills. There is the video on the liver. All right, abdominal evisceration. So in most cases we're talking a penetrating trauma here. So the abdominal evisceration sometimes occurs through a stabbing or a shooting. A lot of times it's probably related to a blade, simply because something went in, depending on where they were with an inhalation versus an exhalation, and so on and so forth. Some of that abdominal content may have come out. This is actually a fairly minor one in the grand scheme of things, because this is really more of a covering, the omentum that is protruding out here. We don't actually have a big loop of bowel coming out, which is a little bit more severe of an incident. So try to determine the size of the object used to stab them or the caliber of the gun used to shoot them. That helps us project and look at what is the potentials for injury here. So if we know that this person was stabbed with a 2-inch pocket knife blade, we have a fairly limited range of what could be injured with that. Whereas if the person was stabbed with a 6-inch hunting knife, just about anything in that cone of a 6-inch range could be injured. So there's a lot greater possibility for injury. The caliber of the bullet, 22 caliber bullet, so a relatively small firearm, doesn't have tons of energy to get out. You may not have an exit wound, but it tends to tumble around in there. But the cavitation of a 22 caliber bullet is not nearly as large as something that, say, a 45 caliber bullet, which is going to go in, roughly a 1/2 inch in size and come out probably about 4 inches in size on the other side. So. And then that abdominal evisceration, like we mentioned. Look for multiple wounds. Do we have entrance and exit wounds? We may not have entrance and exit wounds. We may have multiple entrance wounds. I can recall a call early in my career as a paramedic where we had a person who had some significant psychiatric problems. Were fairly new onset psychiatric problems, but significant psychiatric history, I guess, and was convinced that her grandchild was the devil, and took a kitchen butcher knife and stabbed her grandchild 21 times. It was obviously a fatal incident, but it was not a good thing. So you potentially can have those people that just go crazy. You know, you might have something like a shotgun incident, close range shotgun. You might have, you know, upwards towards 100 small holes that have penetrated this person in various depths and places. So look for multiples. So let's recall how to care for an abdominal evisceration. Some very specific steps we need to take in this. So obviously we need to identify it. This is one of the reasons why we got to make our patients naked. It's very possible that this person wouldn't even have a visible loop of bowel like they do here protruding. So that's why we got to strip them down. So cut the clothing away from the wound. Don't be picking it out. Don't be pulling things away. If it's stuck in there, leave it alone. Otherwise, get all the easily removable tissue or easily removable materials away from it. Soak a dressing with sterile saline. If we happen to have warm saline, that would be great. We don't always have that available to us, but warm sterile saline on a sterile dressing. Place that over the wound, so cover up the wound with obviously the moist side down. Put a moisture barrier over the top of that moist dressing. We want to try to preserve as much heat and moisture as possible. If those organs dry out, it causes catastrophic tissue destruction because that tissue starts to break down because it's dried out and it's dehydrated. So cover it up with a moisture barrier. We also will then try to maintain some warmth to that. Usually we recommend taking and applying a folded up blanket over the top of it, which provides several layers to maintain the warmth. And then of course you're going to secure your moisture barrier down, but if you can also secure your blanket over the top of them as necessary. We're not putting excessive amounts of pressure on this unless we have some sort of like an aortic rupture or aortic bleed there. We're not going to put excessive amounts of pressure on this. Putting lots and lots of pressure on it obviously can cause leakage of abdominal content. So we're actually kind of gentle in the way we approach this. We may also have impaled objects. With your impaled objects, don't remove an impaled object. Leave it in place. As a result, this often can cause an uncontrollable hemorrhage if they remove the object. I've heard some pretty reliable descriptions of the crocodile hunters' injuries. I think we all remember from years ago Steve Irwin, who had significant exposure on television through a variety of routes, was out and was actually shish kebabbed by a stingray right through the heart, or right next to the heart actually. And he reached up after that barb broke off in his chest. He reached up and pulled it out, and was dead very short time after that. So I have heard reports that it's very likely he would have survived had he not pulled that out. It's something that if they had been prepared, and had a couple IVs ready to go and a surgeon ready to get this to pull this out, they could immediately take care of any bleeding there and then be good. But So when we pull things out, we can have a significant amount of bleeding. So don't forget to stabilize the object into place. This is really no different than what we've done at the EMT level. Lots of big bulky dressings around. Be very, very careful. The larger the impaled object, the greater chance of something getting knocking it, bumping into it, catching on it, whatever, and actually causing more severe damage. I have seen video of a person who was stabbed in the chest with a knife, and the stab wound, the blade of the knife actually came in and it missed the heart, but was sitting right along the pericardial sac. And every time this person's heart beat, it did cause that knife to vibrate or kind of jiggle a little bit, cause the knife handle to jiggle every time the heart beat. And that would be one that we'd want to be cautious, but don't get overly wound up in making sure that there's absolutely no movement there, because if we go over the top to make sure that that doesn't move one bit, we actually are going to probably have the heart cutting itself on the edge of the blade there. So a little common sense has to be used in some of these cases. Internal bleeding is going to be our major concern, of course, with blunt trauma. Yes, it's going to be bad if we have hollow organs that are spilling acids and content into the gut. However, that is something that will be taken care of over time. That's something with antibiotics and medication can be taken care of, whereas the bleeding is an immediate concern. So usually from direct injury to a specific organ is where we'll see that bleeding. Again, we're going to concentrate on our ABCs. And then immediate transport. IVs. We haven't brought up IVs really throughout most of this chapter. And they are not a primary fix, but they may be they may assist us in some of the symptom control, signs and symptom control that we're hoping for with these patients. So if we can give them some fluids, remember we're going to base our treatment really on permissive hypotension just a little bit. We're not looking to restore them to a normal blood pressure, just to a blood pressure that's good enough to keep their organs perfused. And but oftentimes, even starting an IV or an IV lock, if we don't have severe bleeding, gives us that opportunity should we need to give them some fluid or should we need to give them some medication. So, the diaphragm, diaphragmatic rupture. The diaphragm obviously is our primary muscle of ventilation, separates our thorax from our abdominal cavity. We can rupture that diaphragm, basically tear it open, tear a hole in it, and some of that abdominal content can then protrude up into the thoracic cavity. So we'll get a loop of bowel in many cases. While this isn't a terribly common thing, the most common thing you will see with a diaphragmatic rupture is a loop of bowel that then protrudes up into the chest cavity. It's going to cause basically a hernia and cause some strangulation of that bowel. It's going to also create a pneumothorax per se, and it's going to make ventilation for this patient much more difficult. So it's something we may even have to ventilate a patient because they're losing their own ability to ventilate themselves. We can have deceleration injuries. Remember Newton's first law of motion: object in motion stays in motion until acted upon by an outside force. And the impact of those organs can result in laceration and rupture. So again, that third collision in the three collision theory, so the vehicle versus the other object, the body versus the vehicle, and then the internal organs versus the inside of the body. And so that impact can cause them to rupture, can cause them to tear, or it can cause some small lacerations as well. Explosions. The hollow organs are typically the ones that are more prone to injury from the explosion because they usually have some gas in them. And when they're filled with gas, that gas is going to change sizes with the pressure wave that comes through, and that pressure wave can cause them to have large fluctuations in the volume of gas that is in their hollow organ, causing it to rupture, and then it will then start to spill out some of its content. Remember, when hollow organs spill their content, they cause a peritonitis, where that content starts to more or less digest and eat away at some of the linings on the outside of the other abdominal organs. And where it's not going to be an immediate thing, over time it obviously does cause some issues. But in most cases, as long as we don't have a lot of blood vessels involved, we typically don't have an immediate emergency. So here we are wrapping up the chapter. Remember, the threat of life-threatening injuries is very high with abdominal trauma. Abdominal eviscerations and impalements certainly have unique care considerations. In cases of intra-abdominal hemorrhage, the patient can deteriorate quickly and progress into shock, and then rapid transport to an appropriate facility is going to be a key to this patient's survival.